Hi friends, I am Dr. B.V. Rao of Usha Clinic and founder of the websites qmedicaldoubts.blogspot.com and raghavamedicaldoubts.com. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatment and surgery details when necessary for the medical knowledge to general people and for reference to medicos. Today I am going to discuss about the renal tract obstructions and management. Obstructions of urinary tract. Obstructions of flow of urine from the kidney, pelvis, ureter, bladder and urethra is a common disorder causing stasis and a rise in pressure within the urinary tract, which may cause infection, stone formation and renal failure. Obstruction may occur at pelvic-ureteric junction, ureter, at the neck of the bladder or in the urethra. Obstruction at the pelvic-ureteric junction causes hydronephrosis. Obstruction at ureter causes hydroureter and then hydronephrosis. Obstruction at bladder neck or urethra results in distension of bladder, hypertrophy of muscles of bladder, trabeculation and hydroureter, and lastly hydronephrosis. If obstruction not relieved, slow progressive destruction renal tissue occurs. Superimposed infection may cause cystitis, ureteritis, pyonephrosis occurs causing rapid damage. Clinical features. Clinical features may vary according to the site of obstruction. If it is supravesical, the renal colic may occur when the onset is sudden and with infection causes fever and dysuria and sometimes hematuria. When the obstruction of below the bladder, there is difficulty in the micturition, thin urinary stream, complete retention and distension of bladder, which is palpable, anuria and overflow incontinence ensues. Treatment. In all cases, the objective is to remove the source obstruction as the urinary calculi or prostate. In case of stones, it is necessary to relieve the obstruction to preserve the renal function. The action required varies with the nature of underlying disease, but sometimes it may be dealt with initially and temporarily by draining the kidney by nephrostomy, ureterostomy, suprapubic or urethral catheterization. Antibiotics given if the infection is severe, but it is advised to wait till the obstruction has been removed or relieved. When the hydronephrosis or pyonephrosis occurs, one kidney and is severely damaged, nephrectomy is indicated. When both kidneys are affected, appropriate treatment of renal failure should be given. Renal and vesical calculi. The urinary calculi may vary greatly in size, from size of sand to a big stone in the bladder. Staghorn calculi fill the whole of the renal pelvis and branch into calyces. Deposits of calcium may also be present, though throughout the renal parenchyma, called nephrocalcinosis. Usually occurs in the case of hyperparathyroidism, renal tubular acidosis, vitamin D intoxication and in healed renal tuberculosis. Clinical features. Clinical features vary according to the size, shape and position of the stone and the condition of underlying tissue. For a long time there may be no symptoms. There may be intermittent dull pain in the loin or back, increased by movement or a sudden jolt. Renal colic. A renal colic means the pain of renal area is caused when a stone is small to enter the ureter or big enough to obstruct an attack of renal colic to develop. A sudden pain starts in the loin, then radiates round the flank, then to the groin, and often to the testes or labia. Pain suddenly increases in intensity and reaches its maximum in few minutes. Frequency and hematuria. Blood colored urine due to blood may be present. The patient is restless, changes the posture frequently to have relief. There is pallor, sweating, vomiting, and may groan into agony. The pain, if not attended, there may subside in about 2 hours or may continue for several hours or days. The pain may be continuous or intermittent with relief in the middle. Investigations. Diagnosis may by history and microscopic examination of urine showing RBC, radiological examination and retrograde pylography. Intravenous pyelogram. There may be necessary in case of about the cause. During the pain, appropriate investigations should be carried out to find the cause of renal calcification or lithiasis. Treatment. Rest in bed is the immediate treatment of renal pain. Application of warmth to the seat of pain. Administration of drugs analgesics for pain relief like pethidine or morphine and antispasmodic drugs as atropine sulfate given intramuscularly and repeated according to the anesthesia. Attempts to dissolve the stones in the kidney have not been successful. So stones in the kidney and bladder must be removed surgically. Stones in the ureter usually pass naturally if left alone. Surgical removal is apt to be followed by stricture and other complications. If pain persists and intolerable, the insertion of a ureteric catheter is often followed by the passage of the stone. Urgent surgery is necessary in case of anuria or the stone is not moved for some months or hydronephrosis is developing or there is continuing infection in the urinary tract. A stone more than 1 centimeter in diameter requires surgical treatment. Diet control. In idiopathic hypercalciuria, a diet low in calcium by reducing the intake of milk, cheese is advisable when diet restriction is not possible. Bendrofluoxamine 5 milligrams a day reduces urinary calcium excretion by about 30%. Alternatively, cellulose phosphate 5 milligrams TDS which binds calcium in the diet. The diet having more of oxalate or as rhubarb or spinac may be tried. To avoid the liver, kidney, sweetbread, fish roe, sardines and spots, articles with very high purine content is advisable in persons who have passed several uric acid or urate stones as may occur in gout or in patients with leukemia. The treatment may also be supplemented by the use of allopurinol. Since the distribution of phosphorus occurs so widely in foodstuffs, dietary restriction for the treatment, phosphate calculi are found only in alkaline urine. Hence, acidifying the urine by administering the ammonium chloride daily may be effective. The crystalline and urate stones may be prevented or sometimes dissolved by making the urine persistently alkaline with a high output of urine. The important therapeutic and phospholactic measure for all forms of stones is the provision of an adequate fluid intake, which assists in preventing deposition of crystalloids in the renal tissue. The daily output of the urine of at least 3 liters is advisable, hence the intake of fluid should be approximately 4 liters daily. If the climate or the patient's occupation causes much sweating, the fluid intake is greatly increased. That's all about the renal tract obstructions, and in the next video I will discuss about some other disease. Thank you.